Hello, everyone, and welcome to the Toronto General and Western Hospital Foundation's second virtual Q&A. I'm Christian Cote, host of UHN's Behind the Breakthrough podcast. We're so glad you could join us. We are grateful to you, our community support. Our community of supporters. We want to start by saying thank you on behalf of the foundation and all of UHN. Today, we're bringing you a rare glimpse of what it's like inside the UHN emergency departments during the COVID-19 pandemic. Our emergency departments at Toronto General and Toronto Western hospitals have seen over 300 COVID positive patients, and that has demanded an entirely new way of working for Team UHN. Everything from caring for patients with the virus to staying safe so that they and their family members don't get sick. Here to give us a first-hand account of what's happening here are Dr. Erin O'Connor, Deputy Medical Director of UHN Emergency Medicine. Welcome, Dr. O'Connor.
Happy to be here, Christian.
And Nicole Harada, Registered Nurse and Patient Care Coordinator. Welcome, Ms. Harada.
Hello, happy Thursday, everybody.
As you can see, the three of us are all in different locations to practice physical distancing and help continue to flatten the curve. All right, first, probably one of the biggest questions, and we wanted to put this to both of you, on everyone's mind is, what are you seeing in terms of the coming through the doors of the emergency departments in terms of COVID-19? Nicole, how about we start with you?
Yeah, so we're seeing a combination of really the regular emergencies that would normally come in, as well as patients who are coming in with possible COVID-related illness. Some of those patients are higher acuity and need very emergent care. And then some as well have slightly lesser symptoms. There is an assessment center around the corner, which is helpful to reserve the really severe cases for the emerge for us to deal with. So that's very helpful.
And Erin, in your capacity, what are you seeing every day?
I think that what's surprising us the most is the breadth of presenting symptoms that COVID positive patients are having. I think at the beginning we were very much fixated on fever and upper respiratory symptoms, and now we're beginning to realize that patients are presenting testing positive for COVID with rashes, with abdominal pain and nausea, even with neurologic complaints or chest pain. And so our list of things to be suspicious about is getting longer and longer every day.
Thanks so much to both of you for that sort of framing of the narrative today. Let's get to the rest of the questions that have come in. And again, we've had terrific response from everyone, well over 170 questions. We'll try to get to as many as possible. You can actually vote for the question or questions that are most relevant to you. If you go to slido.com, type in the event code to my left, that's hashtag X936, and click that little thumbs up symbol in the upper right-hand corner of the questions you want to bump up the queue. So first question goes to you, Nicole. To the emergency nurse, what's a day in the life like during all of this?
Yeah, so, when you're coming into the department, you're normally doing the same things as you normally do, getting changed, putting on your scrubs, coming into the department. But really it's when you start seeing patients and assessing and triaging and all that sort of stuff that some things have changed. Everyone is screened at the door for the symptoms. So making sure that they've been screened and putting them in the appropriate places, and that we're wearing the proper protective equipment to care for them and assess them, do their vital signs, all that sort of stuff. So that's really important. And then before going into rooms, making sure that, are they on the proper precautions? Are they, do I have all my materials really ready? Because it's very timely to dress up, put on all the proper equipment. So if I forget something, it's harder for me to come back out. It's a lot of reassurance for patients too. Patients as well as everyone is anxious about what's going on. So it's a lot of reassurance and support in that way for patients.
Thanks, Nicole. Next question that's come in is, what's the hardest part about working in the ED right now? Is probably, we might have both of you address. Is there anything the public can do to help? Thank you for your work during this and always. Erin, why don't we start with you?
Well, first of all, thank you for the thank you. We love to do this work, and we're honestly happy to come to work every day. I think the hardest part is that we're still not quite sure how this is going to go. And like most of the public, we're wondering how long this is going to go on. One of the positive features is that the curve does seem to be flattening, and we haven't had this surge of patients that's overwhelmed the department like happened in New York and happened in Italy and Spain. And so we're quite happy about that, but we're kind of staying constantly vigilant that that surge could come anytime and it could come from unexpected places. So I think that that's a bit challenging for us. When it comes to what the public can do to help, certainly, you are really the front line, the public. We're kind of the last line. But you practicing physical distancing, washing your hands well, minimizing your trips outside, we can already see the effects of that. And that's really honestly saved our healthcare systems in many ways. So keep doing what you're doing, everybody.
Great advice. Nicole, did you want to add anything about the hardest part of working in the ED right now? It looks like we may have a technical difficulty there. One other thing I want to mention in terms of any way of the public helping is if you wanted to help out in terms of donating supplies or support items to the hospital, you can email COVID support, all one word, covidsupport@uhn.ca, and someone at the foundation will be glad to help you out. All right, next question. Is it business as usual in the emergency department? Is it safe to attend the emergency department? And this looks like Ojibwe, if I'm correct. Chi Miigwech. I guess Erin will put that to you. That means big thank you, if I'm not mistaken, in Ojibwe.
Thank you so much. It is business as usual in the emergency department. I would say that the emergency department is one of the few places in the healthcare system that can ever not be business as usual. We are always open for emergencies. And I first want to address the safety issue. We have seen a change in visit volumes, and there is data that's coming out from New York and Italy that seems to suggest that people are presenting fewer things like heart attacks and strokes are presenting to the emergency departments. And that's not because there's some protective factor at play here. We think it's actually because people are avoiding presenting to the emergency department with their emergencies. And we would strongly caution against that. We have spent thousands of hours, trust me, thousands of hours since the end of December preparing for this and preparing to make our emergency departments safe. So we have changed everything from our housekeeping protocols and the amount of staff to the PPE, to the screening that we do for staff in order to keep our patients safe. People often think that we're wearing the procedure masks to keep ourselves safe, but the procedure masks are actually worn to keep you safe. And so I can't stress how much effort has been put into that to try to protect our patients. So absolutely, if you have an emergency, the emergency department is where you belong.
Thanks, Erin. That's great advice, because I know during a project I've been working on behind the scenes with another emergency doctor, a colleague of yours, Don Lim, taking pictures for us. We've noticed empty emergency departments for long stretches of time. So that's great advice. Like, do not avoid if you are very sick or ill. Next question. Will we see permanent changes to the emergency department because of COVID-19?
I think like anywhere else in society, we are certainly going to see some permanent changes to the emergency department. I think that this will change, how we approach many things, how we wear PPE, how we isolate patients. I think that moving forward in the future, this will change the design of emergency departments, and we will be more focused on having rooms that can be made into negative pressure rooms where people can be seen as individuals. I think that some of the advances that we've made with virtual care as well will be permanent changes to the emergency departments. So, crisis always leads to innovation, and so hopefully some good can come out of this.
Right. We sort of opened with this next question in terms of the answer for that, but maybe you could go into a little more detail for us, Erin. How many cases of COVID has UHN's emergency department seen? And my understanding is it's 325 cases and counting, but maybe you could break that down for a little bit in terms of how many have gone straight to the emergency department, some have gone through the assessment center, and what's happened in terms of discharge and up to the ICU, et cetera?
Mm-hmm. So the vast majority of those patients, we're close to 350 now. Still, again, counting, of course, but the vast majority of those patients have been able to go home and have been able to stay at home. It is a fairly small percentage that gets admitted to the hospital, somewhere around, I believe, at last count, 15 to 20%, and an even smaller number of those that end up in the ICU. Now, we've seen a few more cases at UHN that have come from other hospitals because we have a very advanced intensive care unit and the ability to do many things that community hospitals are not able to do. We do have patients that are transferred from ICUs at smaller hospitals so that they can take advantage of some of the more advanced treatments that we have at UHN. So there is a minority of patients that come in and are admitted that don't actually get seen in the emergency department. We certainly have many that have come in, and many that have come in as suspected COVID, and through the department, and then many through the assessment center, of course.
That's great. Next question, we've, I think, answered in some ways, but perhaps maybe we speak to the fear part, Erin. It doesn't hurt to reiterate it. I'm scared to come to the emergency department. What does the process look like for regular and suspected COVID-19 patients? Is it the same?
So certainly, I hope we can put your fears to rest. And even though we all look like we're kind of in spacesuits, there's not a reason to be frightened. Someone was mentioning at one point when we were speaking about this that it was hard because in many of the ways that we relax patients is by sitting on the stretcher and smiling, and people can't see us anymore behind all the masks, so we're not able to do our usual level of reassurance. Luckily, jokes still translate through the masks, and we're able to help. So the process really is that everyone is screened even before they see the triage nurse for any symptoms. And the list gets longer every day as we discover a new potential symptom. And then people are escorted as much as possible directly into a room. And particularly if they screen positive, they are into a room that is isolated from the others. We wear PPE for every patient we see in the ED. And that's again to keep our patients safe so that we're not cross-contaminating even if someone is potentially asymptomatic. So, and then after we see patients, the rooms are very well cleaned by our very excellent housekeeping staff before another patient comes in. So we are being extremely careful and mindful of the fact that there's high turnover in our departments and of patients, and that any one of them could be COVID positive. So we always want to make sure we protect the next patient.
And the regular patients with other ailments or whatever that need treated, they are taken to a separate part of the emergency department to be triaged.
So they're triaged in a different part of the emergency department, but they are seen in the regular part of our emergency department. For now, our volumes have not been overwhelming. And while we have individual rooms, we have people in individual rooms. So while the room next door may have a patient that we're working up for COVID, they are kept entirely separate from you and separated by a wall. And of course, everybody's donning and doffing their PPE in between rooms to keep you safe.
Right. Great. Next question, Erin. What sort of research is coming out of the emergency department around COVID-19?
Oh, this has been exciting for me. We have been so very successful in getting grants and funding money, and we have some really innovative staff coming up with some wonderful ideas. So I'll talk about a few of the projects. One that I'm involved in is called the HEROES trial, and this is actually looking at a drug that many of you may have heard about, hydroxychloroquine, and looking at it not in its treatment form, but as prophylaxis, so pre-exposure prophylaxis, similarly to how you take medications to prevent against malaria when you go to Africa. We're using this for healthcare workers, everyone who works in the emergency department, so not physicians and nurses, but housekeepers and porters and security, and everyone who works on our team is eligible for enrollment in the study. And they're randomized to hydroxychloroquine or to placebo. And we'll see if there is a difference in who actually tests positive, and if people test positive, if there's a greater number of asymptomatic people with this trial. There's another trial called ECT, which is looking at biomarkers to see if there's a way we can determine from inflammatory markers in someone's bloodstream at the time of their presentation whether they're likely to get very sick. One of the big unknowns with COVID is we can't always tell at the beginning who is going to get sick and who isn't. You've heard reports that many people with lots of medical comorbidities or who are older are at higher risk, but we certainly know that young people get COVID too, and they can get severely ill. And we don't really have a good way to predict that. And so that study is helping with that. There are a few other studies. I could talk about this forever, though, so you may have to cut me off. But one of our, sorry, Christian. Okay. One of our staff noted that it's really hard for us and for public health to reach patients that don't have access to a phone. That many of our population in the emerge that we serve have fewer resources, and not everyone has a phone, though it's something that many of us take for granted. And that makes it hard for us to follow up with tests, follow up with appointments, and for public health to reach out to them to make sure that people are isolating and to check on their symptoms. And so she developed a partnership with one of the telecommunications companies to have prepaid SIM cards and phones, and looked for donations from all of us. Actually, it was a public donation of our old flip phones, and patients are actually, who don't have a phone, are receiving a phone on their discharge so that they can stay connected with the healthcare system and continue to isolate properly. And it's been such a massive success so far. And of course, we're researching that project as well to see if that affects health outcomes going forward. So lots of great innovative work that's being done.
It's great to hear too, because this is also, in terms of research, the type of work that donors that are listening in today are helping to support and finance. So that's great to hear how you're advancing this type of research. I understand we have Nicole back. Great to have you back, Nicole. Perhaps I can throw a question back at you. Next question: when people say shortness of breath as a symptom, what do they mean exactly? What are you seeing in the emergency room?
Yeah, sure. So sorry about that, technical difficulties in the online world. It's something, but I'm back. So shortness of breath. It depends on each individual kind of experiences it differently. With severe shortness of breath, it's very noticeable when you're at rest. You can notice that you're breathing a lot faster. You might have to use more muscles to kind of take a deep breath, and you just don't feel like you can get a full breath. In other scenarios, it might be, you're walking somewhere where you normally walk, and all of a sudden you're finding, I'm really out of breath. So that's another way to kind of keep an eye on how you're breathing. And in the emergency room, it's a combination of anywhere from, they really can't catch their breath and they're breathing very shallow to, it just doesn't seem quite right. I just feel like I can't quite catch my breath. So it really depends.
And Erin, I know you have experience with perhaps, I guess, the next stage of that concern in terms of breathing. Do you want to maybe add to that in terms of, you've done an actual intubation on a COVID patient, correct?
A few, yeah, yes.
What takes you to make that decision or take that step with the patient?
So it's interesting with COVID patients, as opposed to many other patients who present with respiratory distress, they are alert and awake and still able to talk. They're breathing heavily, but their oxygen saturation, which is a percentage from 0 to 100%, though I have to say I've never seen a 0 in a live patient, but most people are around 97 to 100% oxygen saturation, so the level of oxygen in their blood. And we get concerned usually when people are under 90, that's considered more serious. We put oxygen on. And many of these patients are coming in still alert and awake and talking, but with saturations in the 50s or the 60s, which is something in my experience in emergency medicine and in other critical care medicine, I haven't actually seen. Most people are not at that stage alert and awake and talking. They're very sleepy, very drowsy, and it's a very different situation that we're all facing. And this has been reported in other centers as well, and coming up on a lot of the emergency medicine blogs and case studies and that kind of thing. So I've had a few patients who have come in with SATs like that. And what we do is we put them on a full oxygen mask, but we have to be very careful because at higher volumes of oxygen, there is the chance that people will aerosolize, so that droplets will become fine droplets with virus in them and then get out into the air. So we have to be very careful and change our PPE so that we're wearing the more advanced sort of PPE in that situation. And with these patients, what we're seeing is that their oxygen saturation will go up a bit, but it won't come back to normal, even with these really high volumes of oxygen. And then we move to the decision to intubate, which is when we give patients medication to make them sleepy and unaware of what's going on. And we insert a breathing tube into their lungs and then have a machine breathe for them. And it allows for people to have their lungs rested a bit and to make sure that we're giving as much oxygen as possible and to change the pressure at which we're giving oxygen to allow more efficient spread of oxygen into the bloodstream. And so that we go through a consenting process with the patient. If in these situations we're talking to the patients directly, usually we're talking to family members by that stage, but we're talking to the patient, letting them know what the pros and cons are and what they're going to go through. And then usually I try to, at the very last minute before I give them sedating meds, reassure them that they're in good hands and that we'll see them soon and that we're going to take good care of them. It has to be frightening. And it's a situation where they're just seeing me and my mask and my kit and not their family members. And so we try as much as possible to make that human connection at that moment as well. We have a team of people around that do that. And we give medication and then we insert the breathing tube. Now, with these patients, we're finding that at the moment we give them the medication, their oxygen saturation levels drop rapidly, very rapidly, more than what we are usually seeing. So it really does take a very skilled person to be able to do this appropriately. And so we've worked on strategies around that at UHN to make sure that we're giving the best care to these patients.
Wow. Nicole, back to you. This is a question actually from Susan Freeman, Senate co-chair. Do our emergency staff have the needed PPE, which stands for personal protective equipment, if I'm not mistaken, during this pandemic?
Hi there. Yeah, so we all do have the appropriate PPE to go in and care for these COVID positive patients. I know it's been very anxiety provoking with a lot of media talking about a shortage of PPE and getting the PPE quickly. So, in our Emerge, we have the stores that we need to take care of patients. The PPE is monitored to keep an eye and see if we're using more than we normally do, if maybe our volumes are going up so that we can prepare if we anticipate we're using more. But no one's going without proper PPE.
Terrific. Do you want to add anything, Erin?
I was going to say, having been in a lot of these planning committees, UHN has been miles ahead of other hospitals across the country. I mean, I'm in contact with many colleagues from across the country still, and we were a good 4 to 6 weeks advanced compared to many other hospitals when it came to procurement and thinking of backup plans and backups of the backups and backups of the backups of the backups. It's actually been very impressive. So even though it's been anxiety provoking, I think we all have a lot of faith that the hospital has really put a lot of effort into making sure that we're well protected.
Well, that's reassuring to hear. Nicole, perhaps you could take on this question. How is the emergency room handling the walk-ins? Now, I'm not sure if they mean COVID positive or COVID suspected patient walk-ins or people with other ailments.
Yeah. So, Toronto Western has a very high number of walk-ins in comparison to some of the other downtown hospitals. So we're used to dealing with a lot of people walking in with a variety of severity and issues. Our volumes are lower than they typically would be at this point in the year. So that has helped give the team a bit more time to be mindful of screening, PPE, putting on appropriate PPE and that sort of stuff, which is very helpful. But what's coming through the door is at many times a bit more acute. So it's helpful that our volumes might be slightly lower, but we are still having to use more time with putting on equipment and then dealing with patients who really need a lot of close attention.
Great. My understanding is donors have also helped with supplies of PPE. So that's a real tangible way that, again, connecting you, our donors, to helping people on the front lines, which is terrific. Next question. I have a loved one who works in the ER. How may I support in a meaningful way? Erin, can I throw that one at you?
Sure. I love this question. Thank you so much for thinking of your loved one. I think it's actually a bit of a struggle for our loved ones to send us off to work every day and be worried. I have to say that every time I go to a shift, I get a text message from my mother who lives in New Brunswick telling me to stay safe, and I know it's a worry. My husband, who is an engineer, has been busily working on various 3D printed PPE solutions in case they're needed, and working on ear guards. Nicole, do you have one there? Yes. So these 3D printed ear guards.
Horizontally. Yeah, show us.
Yeah, so this is an example of one, but there's been many people donating these devices, which has been really great saving our ears, because wearing a mask with those loops for a long time, it doesn't seem like it would be irritating, but it really does create sores and stuff. So thank you to anyone who's done that.
So back to Erin, yeah.
Yeah, so that's what my husband's been working on those. I know family members have been working on things like the scrub caps, that kind of thing. But I think the most important thing is to be present, to try to allow people to have their ups and downs and to talk about their worries and their fears, because I think we all have them. And we all have our low moments during this. And so I think that that kind of just open communication, and I will personally advocate for, making dinner every once in a while is always a helpful thing too.
Yeah,
Well,
I'd love to add. Yeah. So I, again, also really love this question. I think the biggest thing is, having a conversation with your loved ones about how they're doing. Sometimes people want to talk about it, sometimes they don't. And, just to try and respect and give them space so they can cope on their own. But then I know my family members, again, are really worried. So starting the conversation to ease their worries as well, so that they know what we're doing to keep safe at work. I think that's really important. I also made a list for my particular partner, laundry, cooking, for me, that's what I think is helpful when I'm busy at work, maybe working a little bit longer than I normally would. But it depends on the person. So that conversation, I think, is really important.
That is terrific, Nicole. I love the anecdotes. And I know, Erin, you have 2 small children, 2 and 4.
I do.
Tell us, because I think this is fascinating. Tell us a little bit about your routine for when you go home from work, in the ER.
It's definitely more challenging than it used to be. So before I leave work, I take off my scrubs and put them in the scrub machine. I bleach my phone and my badge, and then get into my car. And I drive home. And when I arrive in my driveway, I send a text to my husband, who's working from home, and our children are at home, to ask him to move the children away from the door or to take them to another room. As you can appreciate, 4-year-old, the habit was always, when one of us came home from work, is that they would run for the front door and expect a big hug and kisses at the end of the day. And I can't do that. And I also don't want to traumatize my children by saying, oh, no, you can't touch mommy, you have to stay away. So we try to move them out of the way so that I can, the minute I hit the front door, so I leave my jacket in the garage and I come in the front door, that I run then for the shower. and take off my clothes. They go into the laundry and have essentially a decontamination shower before I can interact with my family. But it's certainly been challenging, and there have been times where, you know, they know I'm home and they're chasing after me and I'm trying to outrun them while I get to the shower. So that's certainly been a little bit of a difficulty, and it's hard to explain to toddlers why.
And Nicole, any change to your routine in terms of staying safe under this pandemic?
Yeah, so a couple little things. So I used to kind of bring in my own scrubs that I liked that, could be fun or a bit different. And I'm using UHN's really great. They, especially emerge nurses, they have scrubs that they do supply and they launder here. So at the end of the day, I take my scrubs off here, I drop them, they get laundered here. I don't have to take that home to get laundered, which is great. And then I am similar to Erin, wipe off all the belongings that are coming home with me. And then I go home and I jet into the shower, change my clothes, and do that immediately. I am cleaning a little bit more at home, which is good. Sanitizing things like doorknobs and light switches that I didn't think as much about before, how often we touch some of those surfaces. So that's part of kind of what I'm doing differently after all this.
You just cannot be too safe, can you?
Mm-hmm.
Next question. For someone coming to hospital with a heart attack, has the best practice guidelines changed due to COVID, due to staff space and equipment diverted for that? Erin,
I'll take that one. So absolutely not. We are still following all of the best practices, all of the recommendations. So if you were coming to the hospital with a heart attack and you needed to go to the cath lab right away, you would still go to the cath lab right away without any delay. Staff would wear PPE. You would likely be swabbed for COVID at some point, but none of that would delay your transition to the lab. I know that in some places in the world, they had changed some of their standards and were no longer doing percutaneous interventions for heart attacks. They were moving back to some of the old lysis methods. We have not done that, and we do not foresee a need to do that.
Thank you. This question comes from Harvey Savage. How has the hospital minimized exposure to the virus for people coming to the ER departments? I'm guessing he's speaking to people who don't think they have it. So how do you deal with diverting the non-COVID from the COVID? Nicole, do you want to take that one on?
Yeah, sure. So with infection prevention and control and isolation, depending on the possibility if someone has a virus, we're always very mindful, whether it's COVID-19 or influenza, we're very mindful of where we place individuals who might be showing symptoms or be transmitting. So that really hasn't changed. It's just that a few more people are being isolated because of the wide screening criteria. And as Erin said, the long list of symptoms. So really part of the ease of volumes in the emerge has helped with some of that. Our waiting room isn't shoulder to shoulder. Also within our waiting room, it's difficult, but there's no visitors at the moment. So sometimes that's part of the full waiting room. So that's something that we do to help, but to reassure people that we are separating based on infection prevention and control that we normally would.
And I would just like to say that I really think that the biggest contributor to minimizing exposure to the virus for people is our housekeeping staff. They have been head and shoulders just leading the charge on this, getting protocols in place, getting extra staff, and the amount of cleaning and how frequently they clean everything, I think is really the key here.
Terrific. Next question. Thank you for the work you're doing. Has the ED, the emergency department, gotten any directives on how they can support homeless or otherwise vulnerable populations to effectively socially isolate? That's a tough one, eh?
It's a great question though, because it's an important question. As you can imagine, that people who don't have a home can't go home to isolate. And if you're in a shelter, of course, you can't be in a room by yourself and have someone delivering groceries and food and taking care of those needs. We know that this is a vulnerable population, and then we know that they really need a lot of support. We actually identified this fairly early on in the crisis, and there has been a large effort with UHN, with the City of Toronto, really developing protocols around how we can support people. So, as you know, or as some of you may know, we actually have hotels that have been basically commandeered or rented by the city to house people who test COVID positive from the shelter system. There has been outreach into the shelter system to try to swab patients. We swab many at UHN, and because our turnaround times for swabs are good, they wait in our department. And UHN is also, it will be announced later today, actually helping to donate staff and protocols and support for housekeeping and for IPAC support to a COVID positive shelter in a hotel. I think the contracts are still being signed, so I can't be more specific than that. And even our physicians are helping actually to staff and to outreach those shelters. So we have actually done a lot of work, and even the research project I was speaking about earlier about the Phone Connect project, so giving phones to this vulnerable population, has made a huge difference as well. So this is something it's a challenging problem, but an important one to address. And we've really, I think, made great strides on that so far. Nothing's perfect, but.
That's terrific. Next question, I think it would be terrific if we could hear from both of you. Nicole, we'll start with you. How are you and your colleagues doing in terms of wellness?
Sorry. So I love this question. Our team is really incredible, and I enjoy coming to work and working with this team every day. And, in times of difficulty is when you kind of see people shine. So that's been really great. We started in our daily huddles at the end. We go around and talk about safety issues. This is, we've been doing this for a while, but at the end, everyone shares something they're grateful for. And, one of the most common ones is coffee, of course. But being here and having such an amazing team. So I think that helps and then we do a lot of little fun things. So there was mention of the scrub caps before. So we all have, different versions of scrub caps. Mine is a frozen one. I thought that was fun. I had it made for me, so thank you for who donated that to me. But doing little things like that, making jokes, and we really thrive in difficult situations. We run off of the difficulty and adrenaline of difficult cases. So Emerge is unique in that way. So this is just kind of something a little bit different.
And Erin, for you, balancing being a professional and a leader as well as being a mom, how are you doing in terms of wellness?
So again, I think in many ways, this is what an emergency physician lives for. And all of us who work in Emerge, we thrive on chaos a little bit. So I mean, I have to say, I probably don't eat as well as I should, or exercise, or sleep as much as I should right now. But I have a very supportive family, a very supportive partner and in-laws, and good friends across the country, really. So ones that I work with and elsewhere. And I think one of the good things about doing shift work like we do is that usually at any point of night when you finish your shift, somebody that you know is awake. So, so having even things like Zoom chats with friends, and especially other friends in Emerge, and hearing what's going on in BC or in Alberta, And talking out some of those things has made a huge difference. I mean, I think that the wellness has ebbed and flowed. I think that now we are in a bit of a steady state. We have all of our plans in place that our team as a whole have been able to contribute to, which I think has helped a lot. The level of wellness has improved. But, I think the things that people are appreciating, some of our donors have been really amazing at donating snacks that we can have, because as you can appreciate, many of us are uncomfortable bringing food to work, and particularly in containers that have to go home. Eating on shift has decreased. And what the foundation has done is made sure that there are snacks available from time to time at both sites. That they contributed meal vouchers this week so that people could go into the food court and get a sandwich. And they're small gestures, but they actually mean a lot to our staff. And things like having free parking. So thank you so much for everyone who has contributed to that. It really has made a difference, not really for the monetary value, but at least for us to know that people are supportive of the work that we're doing is so meaningful.
That's terrific. Thanks. Next question. Has there been any transplant patients in the Emerge with COVID? So are there different precautions for them?
I don't specifically know of any who have tested positive for COVID. I wouldn't necessarily know that unless I was directly involved in their care. Most of those patients do tend to go to the general, so I split my shifts between both sites. So I personally haven't seen any. Now, we have been in discussion with our wonderful transplant colleagues from all of the different services, and they have made a huge effort trying to divert their patients away from the ED. So having clinic appointments the next day, virtual visits, phone calls, to try to encourage their patients not to be in the ED, not because they don't trust us or not because we don't want them there, but in order to try to keep them isolated from the rest of the population, knowing that they're more vulnerable, and we all know that. So the precautions, I would say, are not any different, because we are taking that level of extra precaution with all of our patients. So keeping people isolated in rooms, not having people mix, our PPE, our cleaning protocols, we're treating every patient like they are vulnerable and like they could have COVID or their neighbor could have COVID. So we're keeping that same high standard.
Exactly. Nicole, how about I throw this one at you? How has Bedside Manor had to change during this pandemic? Because I know for nursing and nursing care plans, it's been a real challenge, hasn't it?
Yeah, so I mean, when you think of Bedside Manor, I would say that the Bedside Manor hasn't necessarily changed, but we're much more aware of how we're communicating, because when you're behind all of this stuff, you can't see my facial expressions, maybe my eyes. Luckily, I smile with my eyes. It's harder, and so you have to be a bit more mindful on how you're communicating. That's something that's difficult, or asking those difficult questions. But I think it's just about being mindful and taking a little bit of extra time to make sure that they feel comfortable, and doing that question afterwards. Is there anything else that's, worrying you that I can do for you? That's really what we can do for now, and just trying to communicate as best we can without those facial expressions.
Erin, did you want to add anything?
No, I think it's a similar thing, it being able to smile at a patient, and even not being able to sit at the bedside and chat. And I think it's really hard. It's necessary, but it's still difficult that family members can't be in, and visitors can't be in. And particularly when you're breaking bad news, when you're sharing something that's more difficult for a patient to hear, the fact that they have to hear it alone it's not the same, and so we can try to get people on the phone to hear the news, but it's not the same as having their loved one there beside them. So some of these things have had to change. Not all of the changes are good, but some are necessary, unfortunately, to keep everybody safe.
That's right. We've dealt with this a bit. I don't know if there's anything more to add. We can throw it out there. We are continuing to hear about PPE shortages in the news. What is UHN doing to help protect its frontline healthcare workers, particularly the ED. Erin, I think it was a few questions ago, you were saying that UHN seems to be out ahead on this front, and that has also been with the help of donor support, my understanding.
Oh, absolutely. Absolutely. And I would say that UHN has plan A, B, C, D, E. They may even go further down the alphabet, but they have a lot of plans and backup plans. And from what I'm hearing from colleagues around the country and other emergency departments, we do seem to be ahead of the curve on this one. So thank you for everyone who's been able to support and help out with this. I mean, it's so important for us. And when you think about the other questions about wellness and how we're doing and how we're keeping ourselves safe and our patients safe, it all comes down to the PPE. So it's making a huge difference.
Yeah, it's critical. And it's a good peace of mind to know that, the support is there for you in terms of the supply is adequate. Next question. This is from Phyllis Burke. Please clarify who gets tested and why not others do not. It's very confusing. Second question, how can emergency staff be better supported? Awesome, all caps work. Nicole, do you want to kick us off for this one?
Sure. Yeah. So, with COVID-19, it's been really interesting times because things do change very quickly. And I know that the testing, even the symptoms, that's changed over time. You know, Patients who are exhibiting those symptoms who come into our emerge, they're getting tested. If at times, if an individual is high risk, we might be swabbing to test also. But we're following the guidelines that are developed in the larger level at the organization. So that's kind of what we're following. Hopefully that kind of answers the question. I know it is confusing, and there's been a lot about are we testing enough people and all that sort of stuff in the media. But yes, so we're following our protocol that's been developed.
Maybe I could add to this a layer to this question, Erin, to you, is just maybe a guideline for people. When should they come to the emerge if they think they're showing symptoms?
So really, we ask that people come to the emerge if they're having symptoms, if the symptoms are severe or you have another major medical comorbidity. So you are one of the transplant patients, you are someone who's receiving active chemotherapy, you're older, so age over 60, we know that this group is at higher risk. Anyone who has anything that would compromise their immune system, those patients should come to the emerge. If you are fairly well and fairly healthy and your symptoms are mild, we encourage you to go to the assessment centers for testing. Even though you are hearing that our volumes are down, as Nicole was saying, it is helpful for us in many ways for our volumes to be a bit reduced because all of these extra precautions we're taking do take time. And having everybody in a single room means that we do have less space than we did before. So it is actually helping us to get on with the work that we're doing to have our volumes down slightly. We are not testing everyone who wishes a test or has a desire for the test. And that is actually based on Ministry of Health guidelines. The testing criteria has expanded, but for an otherwise well person with stable vital signs with mild symptoms, a COVID test is not being recommended at this point. We have to be mindful of the fact that we only have so many swabs, that supply chains are very different now in a COVID world. We, about a month ago, had difficulty with our swabs because all of our swabs came from Italy. And as you can appreciate, when Italy was shut down, we were very much in a shortage situation. We were able to obtain a different supply, but we're being mindful of supply chains. There's also the other end of the test, which is actually running the test in the lab. This is not an automated process. This actually requires a skilled lab technicians to do properly. So it takes time. And the more lab tests that we're running, the slower our tests get. And that can be problematic when patients need the test in order to know whether they can go to the operating room, whether they need the test to know whether they can go back to a shelter or go to one of the protected sites. The slower the testing is, the slower the whole system gets. And so we have to be careful with who we test. So bottom line, severe symptoms, medical comorbidities, you come to the emergency department. Mild symptoms, you go to an assessment center, but there are very specific criteria for who we test and how we test and why, and we're all following the Ministry of Health's guidelines. They do change frequently, but we are able to keep up with that. And I know it can be confusing to the public. Honestly, I'll be honest, it's confusing to many of us as clinicians. I think most of us are checking the guidelines every day before we start our shift to make sure that we're actually testing appropriately. And thank you for the awesome work. I appreciate that shout out.
Next question. Are the family doctors still supposed to be working? We had routine family doctor questions, and our family doctor directed us to the ER. We think that was dangerous for us and not the proper use of hospital resources, especially at this time. Who'd like to take that one on?
Yeah, I can speak really quickly. I know early on when some of the offices might have been closing because they wanted to prevent people from coming in physically and coming into contact with people with symptoms, more doctors' offices are doing virtual calls and stuff like that. So some of that, I don't know for this individual's case, but some of that might have been a delay in getting some of that stuff prepared. To always follow the direction of your doctor if they believe that. There's also, resources I know online for things like self-assessment with the Ministry of Health, things like that are also tools that I know some people have used in waiting. Erin, I'll let you jump.
So I think it's important for us to remember that family doctors' offices don't have the same level of support we do at the hospital. So I am very privileged in that I come to work every day and there are housekeepers and there is someone who has procured PPE and has it available in boxes for me to use. But family doctors who are running their own business in their own offices likely don't have a big stock of PPE to use. They likely don't have a cleaning system where someone can come in after every patient that they see to clean the rooms, to keep everybody safe, to keep themselves and their staff safe. And when it comes to PPE, it's not a matter of people not wanting to spend the money on it. It's a matter of it not being available and people not actually being able to source it. And it's quite possible that your family doctor, though they had the desire to work, they actually didn't have the appropriate supplies that they needed to keep themselves safe and to keep you safe in the office. And in that situation, it's 100% correct for them to send you to a place where you can be assessed properly and safely. I think, honestly, the family doctors across the province they're working under very difficult circumstances at the moment. And I think that they maybe need a little bit more support from us in acute care, which we're happy to give.
That's terrific. I should point out also, UHN has open forums twice a week. And on today's open forum, we heard that over 60% of UHN doctors, for any of you who have UHN doctors that you see, are now on telehealth. That means they can be consulted through telephone, video conference, or digital platform. So something for, as we go forward, another way to access doctors, certainly at UHN. Next question, we've dealt with this. How is it different treating patients with the new visitor policy? I don't know if there's anything to add to that. I know in this case, essentially, necessity has become the mother of invention. You're using iPads, you're playing music for people to help make them feel more comforted, that kind of thing. Is there anything else to add, Nicole?
Yeah, I think for me to add that, obviously it's very difficult being in an emerge for a patient. But part of that difficulty too is for the family member to be able to advocate and, absorb, especially if they're really unwell, to know exactly what's going on so that they can repeat to the next private provider that they might be seeing when they go home, stuff like that. So that's, I think, really tough for family members. Our team really is a bit more aware and is making the effort to make sure that contact information for family members is available and that they're updated on a regular basis. So that communication part, again, is really important. You said we're working to use iPads or phones to make sure patients can stay connected with their family members, especially if things are going not as expected. So it's very tough. especially for the family members and patients, but we do the best to try and keep everyone connected.
That's terrific. From AJ, is the ER now COVID testing anyone that comes in with new URI? I don't know what that acronym means. I'm hoping one of you.
Respiratory infection.
Thank you. I should have figured a doctor would know. Symptoms such URI symptoms such as a new runny nose. Erin, do you want to take that one on?
So thank you, AJ. So as we talked about, it would really depend on a number of factors. We, again, are following the Ministry of Health guidelines, and someone who is healthy, who does not work in healthcare, who does not work in any of the high-risk jobs, so working at a grocery store, working on the TTC, that kind of thing, who comes in with a new runny nose would not be tested for COVID. That does not mean that they don't have it. It means that their risk is low, and we're recommending that people isolate for 14 days in that situation. If you were someone who worked at a nursing home, if you were someone who worked in a pharmacy or in a grocery store who was healthy with a runny nose, then we would test you per the guidelines. Again,
Nicole,
if the symptom is mild, like a runny nose, we would ask you to go to an assessment center rather than the emergency department for that.
Nicole, this comes from Sophie M. Given your frontline experience with COVID-19, how would you recommend the social distancing emergency closure measures be reduced in the next few months?
This is a really tough question that I think, me as frontline, it's tough for me to answer this. I think probably the ministry and all the professionals who are doing policy as their pure job are trying to figure this out. I think social distancing is really important to reducing that spread, but so are basic things like hand hygiene and not going to work when you're feeling unwell are so important. So it's hard to say how the emergency closures are going to affect when they start. If we're still doing some of those things, it'll be interesting to see. I think that it should be done slowly. If it was opened up right back to normal right away, I think it would be really challenging for healthcare and our departments to manage a huge influx of patients. But if it was gradual, we could build up, we could put things in place. But if it was very drastic, it might be difficult. So it's a hard question, $1 million question.
Absolutely. Next question, Erin, I'll throw this one at you. What are the major changes to emergency medical services enforced by the COVID-19 pandemic Ontario government?
I think really the major changes have been around the use of PPE and the use of PPE for all patients coming into the ED, the universal masking on shift for all of our emergency workers. So those are the big ones. There are potentially changes that will come from this, but at the moment, I think we have to be careful with major changes, that major changes really serve the purpose at the moment and aren't just for the sake of making big changes. Remember that when a system is in crisis, big changes are actually hard to absorb. So really it's been around the PPE when it comes to the changes.
Thank you. And you know what, we have very quickly, it seems, come to the end of our time, unfortunately. To all of you at home, we want to thank you for taking the time to join us, and we hope you found the discussion informative. I want to thank our guests who took time from their busy schedules to be with us. That's Dr. Erin O'Connor, Deputy Medical Director of UHN Emergency Medicine. Thanks, Erin.
Thank you, everyone.
And Nicole Harada, Registered Nurse and Patient Care Coordinator. Thanks, Nicole.
No, thank you. Thanks for having me.
To both of you and your colleagues, we want to say a heartfelt thank you for what you do every day during the COVID-19 pandemic, caring for patients and staying safe yourselves. You too and the rest of your colleagues across UHN are truly courageous, and we are grateful for your service. This live stream, just so everyone knows, will be available and accessible anytime. Just go to the Foundation website. You can watch again and share with family and friends. We'll be sending out a short post-event survey so you can let us know what you thought. And as always, Donor support is critical to the work that goes on here at UHN. Right now, we need support more than ever. That's to help staff such as Dr. O'Connor and Ms. Harada on the front lines during this pandemic, as well as the researchers behind the scenes working day and night trying to find solutions to eradicate this virus. If you're looking for a way to help, we ask you to consider making a donation. Visit www.tgwhf.ca/help now. Every dollar counts. And as I mentioned earlier, for people interested in donating supplies or support items, the kinds of things that Erin and Nicole were talking about earlier, you can email COVID support, that's all one word, COVID support @uhn.ca, and someone at the foundation will be more than glad to help you out. As we sign off today, we are going to leave you with a short video about the Emergency Medicine Department at UHN. Thanks for tuning in, everyone. Stay safe, keep physical distancing, and sheltering at home. Thanks very much.
In the Emerge, we're doing some amazing work.
When the big emergencies happen, I want to be in the room. We are in dire need of funding.
We need more resources.
We have patients in the hallways.
It's hard on the staff, but it's particularly hard on our patients.
Any financial donations would certainly make a huge impact.
So that we are ready for what's going to come in our doors.